At the outset, I would like to thank Dr. Satyan sir and the scientific committee for giving me the opportunity. I have no financial disclosures. So I am speaking dry eye evaluation in respect to glaucoma. So one should hear to the patient, you should examine the patient, and also should do some clinical tests for diagnosing the dry eye. So Pisella in his study has found that those patients who used more preserved eye drops had more symptoms than patients who used preservative-free drops. So we can use symptom questionnaires, as already spoken earlier, to evaluate the symptoms in the patients. So these symptom questionnaires can help us in utilizing the patient's time. They also help us to assess the impact on these dry eye on the quality of their life. But they should be able to short and sweet, and they should be able to us to monitor the change in the treatment. So there are many such questionnaires that was quoted in the DUCE study, and the popular one is the OSDI, Ocular Surface Disease Index questionnaire. It incorporates three features. One is about the ocular symptoms, and the other is about the vision related symptoms, and these symptoms, what happens in different weather conditions, whether in humid climates or in the dusty weather. All those effects can be evaluated by using this score. The next we come to seeing the patient. So Pisella also in his study found that those patients who used preserved medications had more signs as per his study. So there are two things. Drug moiety in glaucoma itself and the preservative both can cause the surface disease. So each drug molecule has its effect on the ocular surface. More commonly, letoprost can cause surface congestion, periorbital pigmentation. Miotics can cause conjunctival cicatrization. Beta blockers can cause epithelial keratopathy. Brimodine can cause allergic dermatoconjunctivitis. Also, we should see other eye-related problems that already have been mentioned about the lid abnormalities, meibomian gland morphology, eyelid abnormalities, and all should be examined. Anterior blepharitis also should be examined. So coming to the next moiety, that is the benzalkonium chloride, it has its effect starting from the tear film until the lens epithelium. So the whole of the anterior segment is affected by the benzalkonium chloride. It's phototoxic and has effect on even the cell lines as demonstrated experimentally. So how do we go about the practical sequence of clinical tests? Now we heard from the patient, we examined the patient, now we are doing some clinical tests. So DUCE suggested, the dry eye workshop study suggested, to take the history examination and then do T-BUT first, and ocular surface staining and Shermer test. And later on we can assess some other tests with the help of laboratory. So tear breakup time is the time interval between the last complete blink and the appearance of the first dry spot. Less than 10 seconds is considered abnormal. It's slightly high specific and also sensitive for assessing the stability of the tear film. So you can just use minimum amount of fluorescein to stain. You should not cause reflex watering. If you use excessive fluorescein and if you cause reflex watering, then there will be prolongation, as seen in the video, where there will be, if you use excessive fluorescein and reflex tearing will be there, the T-BUT is prolonged artificially. So you should also ask the patient to blink freely after, should not squeeze. That can also prolong the T-BUT. The next test is the ocular surface staining, the vital staining. Here two dyes are used. One is fluorescein, the other is the lissamine green or rose bengal. So fluorescein stains the areas which are denuded of epithelium, and rose bengal or lissamine green stains dead and devitalized cells. So, but rose bengal is slightly phototoxic and can cause changing. So lissamine green is preserved. There are three classifications that can be three systems that can be used for classifying things. Of all those, Oxford schema is slightly helpful. 5 panels of grading are there, and in each panel you can grade from 0 to 5. The higher the score, the more severe the dry eye. So you should always grade fluorescein immediately because it rapidly disseminates into tissue, whereas lissamine green persists for a longer duration. So this is how the lissamine green staining in a patient who used long-term medications, and also earlier was the fluorescein staining that was seen in a long-term patient, was long-term glaucoma medication using patient, and the other photo is about the lissamine green staining that is seen. Coming to the third test is the Shermer test. We are assessing in this test the reflex tear volume by stimulating the conjunctival sac by the placement of a filter paper. So the normal millimeter is 5 millimeter. Less than 5 millimeter is considered as a dry eye. You should. It is done without anesthesia. That version I am discussing here. So in an unanesthetic eye, you should keep the filter strip at the junction of medial 2/3 and lateral 1/3 without touching the cornea, and ask the patient to close the eye for 5 minutes, and at the end of 5 minutes you assess the tear wavefront level. So it's also a very sensitive test. The next test is the ocular protection index. This test indicates whether TBET is shorter than the blink interval. So ocular protection index, if it is more than 1, it is very much favorable, and if it is less than 1, the patient can have more symptoms, so he is prone to get dry eye. The other test which we can take the help of laboratory is the mucus Ferning test. So here you need to collect the lever meniscus tears with the help of a micropipette and place it on a glass slide and allow it to dry and observe under microscope. You will be able to see these ferns. So this indicates normal mucin content of the tears. So there is a Rolando classification that you can use. So grade 3, that is partial ferning, and grade 4, no ferning, indicates dry eye. The other test is the conjunctival impression cytology. So this is a test where you can take the superficial layers of epithelium with the help of nitrocellulose paper, and this paper absorbs the superficial layers, and you can then fix it over a glass slide with the help of laboratory. You can stain it with periodic acid scheme for hematoxylin and eosilin, and observe for the morphology of the conjunctival cells, and you can also study the corneal epithelium cells also. So this is how the placement of the filter strips have to be done. So just have and you can place the filter strip over the area. I'll keep the lids away from this one, and as you notice in the video, there is some amount of wetting of the paper. If it is more wet, then the yield will be less. You should not allow it to wet. So you should do it properly and press it with the appellation prism, and so that the yield will be more. And you can use the Nelson classification for grading the conjunctival morphology, where in grade 0, normal is more than 500 counts of globulate cells, and normal cells with larger nuclei. Whereas as the grading increases, the cells become larger and the nucleus becomes smaller with decrease in goblet cells. So this is the photo showing the normal conjunctival morphology, where there are more number of goblet cells and also cells with larger nuclei. So this is the morphology taken from a patient who used BAK medication for longer duration with larger cytoplasmic nuclei, with larger cytoplasm and lesser nuclei. The other test is supposed to be thought as the gold standard, is the tear osmolarity test. So this test, although it's gold standard, but is limited available because you have to depend on laboratory, and all laboratories do not possess that microchip which analyzes few nanoliters to give the result in seconds. So the cutoff value is 316 milliosmoles per liter. So as we use the medication for a longer duration, and the more the number of medication, you have more the number of symptoms and more the number of signs. So this was studied in Living et al. Study that was already mentioned about, and all those studies do tell that there are abnormalities in TBET and Schirmer in glaucoma patients, and also in 20% of them there was more of lissamine green staining, and lissamine green staining increased with the number of medications being used. So the prevalence of OSD varies with each test used. So there is no particular clinical test that will tell that this is OSD. So that's so. The other study Madam has done and presented in AAOC 2010 proceedings, they also have the same findings with all the 3 tests, and they advocated use of preservative-free medications and also fixed combination medications to lessen the load on the ocular surface. So in conclusion, you should have a multifactorial approach. There is no single clinical test, and all the studies have told that ocular surface disease index questionnaire will help us to elicit the symptoms, but those patients will have normal clinical tests. They have higher scores on OSDI, but clinical tests will be normal. So in the early stages of ocular surface disease, patients will have more symptoms and less signs. Where in later stages, patients will have neurotropic changes, and they will also have visual field abnormality, vision related problems. So hence, preservative free medication should be thought in future for managing glaucoma. Thank you.